On to number 18. The patient is supine. Use a bilateral thumb contact for a right anterior fibular head. So he's at the head of the table since Ben is supine, and now he's found his right side. For this move, you're going to flex the knee. Now remember, even in ortho-neuroland, he told you not to sit on the patient's foot or to put your knee on their foot. So you do not have to stabilize their foot at all. Their foot will be fine where it is. And he's got a bilateral, or sometimes they'll say reinforced thumb contact for a right anterior fibular head, and he would say my line of drive is A to P. Okay, while we're there, Dr. James, now you're going to be on the other side, but we're going to have the patient supine use an index for a left posterior fibular head pull. So he's locating the fibular head. Okay, he's going to take his index and make a little hook out of his index right on the head of the fibula, and he could actually stabilize the tibia slightly below if he wants to take his left hand and bring it a little bit lower, if that's okay. He is going to stabilize below so that he is not pulling on the tibia, but he's just pulling on that fibular head. So my line of drive for this one is P to A. Number 20, patient is supine. Use a bimanual grasp on the talus for a left anterior talus. So he's found his left side. He's going to flex the foot to find, he's kind of ticklish, but he's going to flex the foot to find the talus using his bimanual grasp, and my line of drive is A to P. Number 21, the patient is supine. Use a pisiform on the mastoid for a PSL occiput. That means it's gone posterior, superior on the left. So Dr. James palpated the mastoid. He's using his pisiform, and he's going to say my line of drive is P to A and S to I. Okay. Number 22, the patient is prone. You're going to use a knife edge, and sometimes they'll say bilateral hypothenar contact on the transverse processes for a T4 body left, spinous right. And we really suggest that you stay on the side of the body rotation for this move. He is palpating down to T4, and he's going to use his knife edge. Okay. And his line of drive. My line of drive would be P to A and I to S, and then you'll pause. Number 23, patient is prone. Use a thumb on the spinous for a C7 body right, spinous left with head stabilization. He went to the foot of the table to find the left side, and he found it because he's going to be on the left spinous process of C7. Now, since his head's...
Rotate your head to this side.
Yep, he's asking him to rotate his head. He tapped his shoulder, too, so that Ben would know what side to go to. My line of drive is P to A and lateral to medial. Patient is prone. Use a cross bilateral hypothenar on the transverse process push for a T5 body right, and they have PL, which means the spinous has gone left. So you go to the foot of the table. He's on the right side of the table. He's palpating down to T5. And he would say, my line of drive is P to A and I to S. Number 25, the patient is prone. You're going to use a pisiform on the transverse process with head stabilization for a T3 body right, spinous left. So since you're on the TP, you're going to be on the right side of the patient. So he's figured out his right side, and he's going to palpate down to T3, put his pisiform on the transverse process. Then he's going to tap Ben's shoulder and ask him to turn his head. Okay. And there's his head stabilization. So my line of drive is P to A and I to S. All right, number 26, patient is prone. You're going to use a reinforced pisiform on the spinous process for an L3 body right, spinous left. So since you're on the spinous process, you should be on the left side of Ben. And he's palpating to L3. Okay. And there's his reinforced. So my line of drive is P to A and lateral to medial. Number 27, patient is prone. Use a reinforced pisiform on the PSIS with the left PIIN ilium. Now you might be thinking, oh no, Dr. James is going to the wrong side, but to correct the IN, you need to step and palpate and to contact across to the other PSIS. So my line of drive is P to A and I to S. You don't have to say anything about the IN because of your hand placement. You're actually correcting the IN position. Yeah, it's moving because of your hand placement. Number 28, patient is prone. Use a double thumb contact for a right inferior right first cuneiform. So you're going to palpate for the cuneiform. You're going to find it. He's found it. Now he's using a double thumb contact. And my line of drive is I to S. Number 29, patient prone. Use a double thumb contact for a right inferior cuboid. So now he's going to locate the cuboid on the right side.
It's the divot.
The divot. And it's a double thumb. My line of drive is I to S. We're on number 30. Patient is in side posture. You're going to use a piezoform on L4 for a L4 spinous for a body right, spinous left. So first of all, Dr. James has put Ben supine. He's figuring out where his left and right are, and now he realizes that the left side has to be up for a push move. So he's going to roll towards him. Now, whichever method you use to set up side posture is fine. Bend the knees, stabilize the shoulder. He's now palpating to find L4. He's on the spinous process with his piezoform. My line of drive is P to A and I to S. Number 31, patient side lying. Use an index. Now, it's not the chiropractic index. It's going to be his index of his hand contact on the mammillary of L3 for a body right, spinous left. Now, our rule is for the mammillary, whether it's a push or a pull, you're going to put that side up. So his right side's going to be up. So we had him turn and face him. He's doing the typical setup that most of you would do. Straighten the lower leg, bend the top. He's going to palpate now for L3. Okay. And he's going to put his knee there, and he's going to take his index, not his chiropractic index, but his index, and he's ready. So my line of drive is P to A and I to S.
I guess I probably should angle a little bit more like that.
A little bit, yeah. Well, I to S and P to A, so it would be angled more towards that way.
I gotta be up here.
A little bit, yeah.
Okay.
There you
All
go.
right, there we go.
Okay.
I don't do this move. Okay.
There we go. Okay. Thank you.
Index, really?
Index,
okay. It's a reinforced index.
Number 32, patient is sidelined. Use a reinforced index now. Contact on the mammillary of L2 for a body right, spinous left. So again, body side's going to be up because it's a mammillary. And he's going to palpate for L2. This is going, it's a pull move.
With your whole body, you tell us, okay.
So he's got L2. And then he's going to reinforce his index. Now you put your knee up there. You don't do the kick though, and he's frozen. My line of drive is P to A and I to S. Okay, on to number 33. The patient is going to be in side posture. Use a hypothenar contact on the PSIS for a left PI ilium. So he wants him turn and face me, please. Realize too that as he's counting for, as he's palpating and getting Ben set up for, on that and getting that PSIS, the hypothenar basically, is your piezoform. So as long as you've got the hypothenar on there, that's fine. My line of drive is P to A and I to S. Number 34, the patient is in side posture. Use a piezoform contact on the spinous for an L4 spinous left, body right. So you're going to be contacting that spinous as a push move. Have that left side up. Okay, and he's going to once he gets Ben set up, he's going to palpate to L4. And he's going to place his piezoform on it, thigh to thigh. My line of drive is P to A and I to S. Number 35, we call this one the shoulder breaker. The patient is in side posture. You're going to use a piezoform contact on the ischium for a right AS ilium. So he's going to have Ben turn towards him. His right side's up. Now, when you contact the ischium, you may want to say to the patient that my contact is going to be the middle of your buttocks so that they know what's coming. Okay. And your shoulder, Dr. James has a real hard time with his shoulder, but you really have to bring it so that your arm is facing down the shaft of the humerus.
And your fingers are going
And
down.
your fingers are going down it too.
The best I can, but
So-
I got a lot of scar tissue
Yeah,
here.
he does. It's a bad arm for him, unfortunately. So my line of drive is P to A and S to I. So we're going to untwist Ben and untwist Dr. James now. They did a good job with that one. Good job, Dr. James. Number 36, the patient is going to be sidelined. Now, they told you specifically, involve side down. Use a piezoform on the sacral base for a P-L sacrum. That means that it's rotated to the left backwards.
down, yeah.
So left side would be down. You're going to palpate the second sacral tubercle and just go slightly to the left of that. So he's palpated it. Get his piezoform there on the sacral base. And my line of drive is P to A and I to S.
All right, now I don't know about you, but I'm worn out. So is Ben. Okay. Now I want you to realize that these things are written both outside the room. The two that you're given are written outside the room, so you have 90 seconds to look at them. They're also written inside the room. So are all the orthoneuros and the physical exam. So everything is repeated inside the room. The thing is, it's taped to the examiner's table. So with the orthoneuros and the physical exam, I kind of like you to write down what you're doing so you're not always going over to the examiner table all the time. But if you had to, in this room, in between the two adjustments, kind of stop, the two setups, stop and then go over there, double check what it is, make sure you have the proper contact, the right side, and then go back and set your patient up. That's good rhythm too, so that's okay. So realize it's written outside and inside the room, so you can double check in case you want to double check your right and lefts. If anything ever shows up, whether it's a new ortho or a new adjustment or a new anything, just do the best you can. Stop, talk to yourself. You got a lot of brain cells up there. Make common sense out of it. Do the best that you can, and just realize it's new for everybody. And if it's a really bizarre new thing, like a whole new part of the test or something, usually they don't have new things count much. So they try them out, so they have a trial period with really new things. But if a new ortho or a new adjustment shows up, remember it's a recipe. They tell you the position of your patient. They tell you what part of your patient, whether it's ischium or C3 body, or they tell you what part you're going to touch, and they tell you what part of you has to touch them. So it is a recipe. Take your time. Remember, these are the easiest points to get, but they're the easiest points to lose. So go slow.